Hi, this is Dr. Bernstein with the June 2018 version of our Teleseminar and Diabetes University. Before we begin, I want to give you the usual warning that my responses to individual questions are generic responses. They're not necessarily going to solve the questioner's problem. The answers are intended to be informational for the bulk of the listener group. So they're meant to be educational, but not necessarily to solve a problem. The reason I cannot solve a problem is because I haven't examined the questioner or the person who's being discussed. I've not gotten his full medical history. I don't know all the medications he's taking, et cetera, et cetera. So I can't really have an accurate answer, but it can be very interesting. First question. Oh no, we have a special subject this week. There was an article published in the May 18th version of Diabetologia, and its title is Advances in Drug Discovery for Human Beta Cell Replication. This is a summary of all of the published studies that are in process for reversing diabetes by causing beta cell replication. Beta cells are the cells that make insulin. And what it points out is that the most advanced of these studies are still many years away from successful testing in animals and even further years away from testing in humans. My guess after reading this was that for a drug cure for diabetes, we're at least 10 years away from successful trials on humans. So if you hear of someone today making claims of a cure, selling a supplement or vitamin or other chemical that supposedly cures diabetes, you can be pretty sure that it's a ripoff. These claims are constantly being made. If you were to search on the internet for a cure for diabetes, you'd probably find more than a dozen of them, and none of them work. There are even reports of studies by legitimate research facilities, prominent universities, etc., claiming cures, and likewise, these things have not been replicated or successful elsewhere. Now we'll get down to our questions. Do you have patients in your practice who have type 1 diabetes and take metformin? What are the reasons for starting or stopping metformin for these patients? Well, in general, I do have many type 1 diabetics who take metformin, and it has to do with insulin resistance. Metformin appears to fight insulin resistance by several mechanisms. And when would a type 1 diabetic have insulin resistance? Well, first of all, if they're overweight. And nowadays, there are occurring more and more overweight type 1s because the powers that be are recommending high carbohydrate diets, and high insulin doses to cover the carbohydrate, and this builds fat. So diabetics are being made fat by the guidelines. So there are many obese type 1 diabetics, and you could reduce the insulin resistance caused by the obesity with the help of metformin. Then there's the condition known as polycystic ovarian syndrome, or PCOS, which affects supposedly between 5 and 15% of women. And this responds quite nicely to metformin, and we use it for them. Many of those people are diabetic and have been classified as type 1 diabetics. Then there are women who during their menstrual periods, or usually the week before the menstrual period, have erratic blood sugars. And that condition seems to respond to metformin also. By the way, when I say metformin, I really mean glucophage, the brand name, because I've found in my patients that glucophage is much more potent than the generic versions. Then we have children with growth spurts. They become insulin resistant while they're growing, and we give them glucophage, and they require less insulin, and their blood sugars are more level. Then people who have been given a shot of prednisone or any steroid tend to have high blood sugars. So it could last for sometimes several months from one injection. Like a doctor injects prednisone into a joint and tells you that the blood sugars will be okay after a few days, and it really takes a few months. Well, we give those people metformin, and that seems to help lower the insulin resistance there. Why would we stop giving a patient metformin? There are two situations. One, if it doesn't work, if it doesn't do the job. Another situation might be if it causes vitamin B12 malabsorption. Now, one can get around this by giving patients calcium pills. The metformin seems to be absorbed at sites, competes with B12 for the same sites on the intestines. And some people develop anemia from poor B12 absorption from the diet. And it seems that if you give a patient a calcium pill like a Tums with every dose of metformin, you can get around this. But I've not seen this for real. I've only read about it. I have many patients taking metformin, and none of them have either had to take B12 or Tums. There are tests to see if you get B12 malabsorption, and I've discussed that in my teleseminars. An overweight type 2 diabetic taking metformin, invokana, Novolog, and Tresiba. My insurance changed, and suddenly the invokana became unaffordable. Do you believe it's possible to manage as well with just the Novolog Tresiba combination without the invokana? Well, first of all, I would recommend that this person read my book and follow a low-carb diet, because the invokana is a new medication for type 2 diabetes that can have some effect on blood sugar, but the effect is not nearly as dramatic as a low carbohydrate diet would. So that's the first thing I'd recommend. And there are many other combinations of oral agents plus insulin that work. In fact, most of my patients do not take invokana. I have one patient, one out of many, who insists that the best blood sugars he's ever had have been while he's taking invokana. So, but he needs very little insulin. He's a type 2 diabetic, and because he needs so little injected insulin, the invokana makes a proportionately greater effect. I am a 39-year-old type 1 with hypothyroidism and obese on an insulin pump. I have a suspicion of insulin resistance And my diabetic team suggested metformin. A1C is now 7.5%, which is an average blood sugar of about 200 milligrams per deciliter. I exercise twice a week in the hope to lose weight. Is there anything else I can do? Well, first of all, we find that people who are on insulin pumps are frequently obese because the message that both the manufacturers who make the pumps and the physicians who prescribe the pumps give is eat all the carbohydrate you want and just increase the insulin bolus that your pump gives for meals, for the meals that you're eating all the carbohydrate. Well, that has two problems. One, insulin plus carbohydrate makes you fat. And two, attempting to do that involves a lot of guesswork, attempting to match the time effect of insulin with the time effect with carbohydrate. You never get the two peaks matching, and you end up with roller coaster blood sugars. I've never seen an insulin pump user with normal blood sugars, except when they're given the pump during the honeymoon period and they're still making their own insulin, and their own insulin is what's controlling their blood sugars, and the pump is really not contributing very much. And then because the pump to some extent interferes with blood sugar normalization, over time, eventually they burn out their beta cells from glucose toxicity, and the pump doesn't work them at all. So I would say, one, you read my book, Diabetes Solution. Two, you switch from an insulin pump to the methods recommended in the book. And it's possible that you may also have gastroparesis, depending upon how long you've had diabetes. It's not mentioned in the question. So if this is a long-term type 1 patient, he may have gastroparesis, and that should be treated, again, as in the book. That's about all I could think of. So I'd suggest that you try reading the book and doing what it says. My daughter has had type 1 diabetes since age 7. She's now 13, and her blood sugar is almost impossible to control. In addition to that, eggs make her blood sugar spike, and I don't know why. Why do eggs make her spike? Well, it's interesting that this parent is not interested in what can be done to normalize the daughter's blood sugars. And that is what would worry me the most. You can always avoid the eggs, but why not control her blood sugars? So I'd suggest that you read my book, Diabetes Solution. And
well, he probably doesn't understand that protein raises blood sugar.
Well, you took the words out of my mouth.
Yeah.
It could be that with a traditional kind of treatment, like 1 or 2 shots of long-acting insulin a day, you think that some foods are going to raise blood sugar and some are not. Well, proteins will certainly raise blood sugar if they're not specifically covered with insulin. So that could be one reason, but I can't answer it because I don't have more information. My guess is that any protein would make a blood sugar spike. Not as much as carbohydrate, not gram for gram, not nearly as much as carbohydrate. I've had type 1 diabetes for 45 plus years and have, no, I'm sorry. My question is regarding menopause. I've had 3 episodes whereby I have felt low blood sugars and almost passed out. Will this pass and become more regular once menopause is complete, or am I in for a constant roller coaster ride? Well, first of all, if you feel low, I would suggest that you check your blood sugars to make sure. But usually there's usually a variability in blood sugars, not just low, but again, roller coaster type blood sugars during menopause, where the hormones are going up and down and are not constant. After menopause ends, blood sugars tend to be more stable. I just got out of 1 week intensive care unit hospital stay, having severe ketoacidosis and being told I am a type 1 diabetic. Medical specialists are insisting I eat an enormous amount of carbs at every meal and that my high sugars are now proper because they are consistently in a high range. I'm frightened and confused. I love low carb and I am told I can no longer do that. Can you help me? Well, you know what's right. Your doctors are lying to you. You probably have to find, first of all, you should read my book so that you would know how to treat your diabetes. Then you would have to probably have to find a kindly general practitioner or family care physician who is reasonably intelligent and will prescribe for you the things that you find you will need after reading the book. How do you find a kindly family care physician? Talk to your neighbors and friends to see if any of them have a good physician who lives in your neighborhood. You could also look at type 1 GRIT, G-R-I-T, and type 1 is spelled O-N-E, on the internet and see what other people are doing. If you show it to your doctors, the chances are they will ignore it, but if you show it to a family care doctor, there's more of a chance that he might take it seriously. This brings up something that I should mention anyway. I was just reading the current edition of Consumer Reports Health, which is a newsletter that's published in the United States. It may be available outside the United States. And they are now have the nerve to recommend that diabetics have high blood sugars, that most diabetics should have hemoglobin A1Cs up to 8%. I have to think, what would 8% be in milligrams per deciliter? It's about 220 milligrams per deciliter. And that patients who have an A1C under 6.5%, 6.5, which would be 160 milligrams per deciliter, double normal, they're suggesting that if your A1C is less than double normal, you should contact your doctor because you may be in danger. This is horrendous. It's like my 50-year battle to get the people who write guidelines to help the patients instead of worrying about themselves is certainly not winning. If you can get Consumer Reports to support to support the, what should I say, the early death and disability of diabetics, I'm really not getting very far. Please discuss the new fast-acting Canadian insulin, FIASP, F-I-A-S-P, used in correcting blood sugars out of range. Whether the diluent used for Novolog can be used with FIASP. If you plan to try it, how potent is it compared to Novolog? I did find out from Novo that the diluent is the same as for Novolog. Whether this stuff is really more potent, whether it's more rapid acting, whether it's stronger or weaker, I have no idea. So the best I can help you with is that the diluent is the same. Type 1 since 1964, so this person is a survivor. What tips do you have for dealing with nausea while on a low-carb diet? Well, diabetic since 1964 would be 54 years, if my arithmetic is correct. I'm an engineer, I should be able to do it right. So 54 years with type 1 diabetes, probably uncontrolled, the odds are overwhelming that you have gastroparesis. And I suggest that you read the chapter in my book on gastroparesis. If you live in Canada, you'll be able to get domperidone, or if you live elsewhere, you might be able to get it. In the USA, it's difficult to get. It's a medication that facilitates stomach emptying, reverses nausea. End-stage gastroparesis involves the possibility of vomiting most of the day. I've known patients whose teeth were worn down by the stomach acid from the frequent vomiting. How many ketones is normal or okay to spill in my urine while on a low-carb diet with good blood sugars? I have no idea. I've never tested my urine for ketones ever since I started measuring my own blood sugars and was able to avoid ketoacidosis. So ketones were high in the urine of humans before the invention of agriculture, because ketones kept the brains alive during famines. Pregnant women frequently have ketones in their urine during the last trimester of pregnancy, when they metabolize the fat that they've been building during the first 2 trimesters. So ketones are a natural thing to have in the urine, and I certainly wouldn't be worrying about them. I don't worry about them for myself. I don't worry about it for my patients. There's no reason to be looking at ketones instead of blood sugars. This is one of the many myths that's being perpetuated nowadays. You should keep your blood sugars normal and don't worry about the ketones unless you have very high blood sugars. Do you have a list of current low-carb products you recommend? I don't really recommend products. I recommend about 20 or 30 different vegetables that are low-carb that are listed in my book. Too many people are looking for snacks, and they think that they can purchase a low-carb snack and eat it all day long and not expect any consequences from it. Well, as I point out in my book, a type 1 diabetic can eat a handful of pebbles and his blood sugar will go up just from distending his intestines. So there are no real freebies. I guess someone once brought in some protein crackers, and they were very small and tasted good, and I tasted one or two of them, but you can't sit and eat them all day long. One or two might raise my blood sugar by 1 or 2 milligrams per deciliter, which is trivial, but to be eating these low-carb foods all day long, you're not going to get away with it. Do you have a list of providers that support low-carb diets to manage diabetes? I would love more support, but don't know where to turn. Well, we have currently in publication, I've had 2 books of with low-carb recipes. My book, Diabetes Solution, I believe, has about 100 recipes. And my book, Diabetes Diet, has at least 100 recipes. So there are recipes for making concoctions, real food that's low in carbohydrate. Maybe this person is referring to doctors. The word providers might relate to doctors, but I don't know of any doctors that advocate low-carb diets. There may be a few. I know of 2 naturopaths, and they're out in the wilderness, and I really don't know anyone else. There are plenty of family practice physicians that will support the concept of low-carb diets, but they don't necessarily tell you how to go about it. You could read my book, Diabetes Solution, for the guidelines. I'm a 56-year-old woman, type 2 diabetic for 3 years. When I exercise at 80 to 85% of my maximum heart rate, it spikes my blood glucose. I go from 85 to over 110. I don't know how to stop this from happening. I've seen this in a few people, and it could be, as Elliot P. Jocelyn told us some 72 years ago, that you're not exercising hard enough to offset the stress hormones that you make when you exercise, your blood sugar will go up. So it could be that she's not exercising hard enough, but she says up to 85% of her theoretical maximum heart rate. Maybe it may not be for a long enough period of time. I don't know. But for some of my patients who experience this, I give them rapid-acting glucophage maybe an hour or 2 before they exercise, and 1 to 3 hours before they exercise. Usually I take a half of an 850 milligram tablet, and that frequently helps. If that doesn't help, you could try taking a whole 850 milligram tablet. I'm a type 1 diabetic and a half marathon runner. I wonder which half. Lately, my feet burn after about 8 kilometers of running, and I'm forced to stop and walk for a while. What could I do to help me overcome the burning sensation under my feet? I don't know why I picked this question to answer, because it's not an easy question, because I don't know why this person's feet are burning. It could be that The pounding does something, and perhaps changing the sneakers to the more springy kind that are available in some places might be helpful. It could be that he has impaired circulation in the feet. An experiment to see if that's the case would be to take a rapid-acting nifedipine capsule when the burning begins to see if it makes it go away. You'd have to chew the capsule and swallow the liquid. The one catch is that it can lower blood pressure, so it should be under doctor's supervision. Another possibility, if you're thinking of circulation, would be to stop and rub nitroglycerin ointment on your feet when you get the pain, and see if that overcomes the pain. Trying to think what else could be the culprit. Well, would it be neuropathy? I would doubt it, because I don't think that the running would make the neuropathy worse. That's all I can think of. You might have to do a few experiments. What advances in diabetes medical care have happened in the years since the publication of the updated 2011 book? That's my book, Diabetes Solution. Well, there's been the availability of Tresiba, which is the longest acting insulin we now have, the Tresiba insulin. There's the FIASP, FIASP, which is now available in Canada and possibly overseas, but I don't know enough about it. There's continuous glucose monitors. There are closed-loop insulin pumps that I do not recommend. In fact, I strongly object to them, where they're making claims of the possibility of normal blood sugars because the pumps have a built-in algorithm that tell them how much insulin to give you for your estimates of carbohydrate and whatnot. And as I explain in my book, can't possibly work, and they don't work to normalize blood sugars. Then there's another new development, was the exposure in the Journal of the American Medical Association about 2 years ago of the bribery that's been going on since the 1960s to blame fat instead of carbohydrate, dietary fat, for heart disease and the high incidence of obesity and diabetes. It seems that food manufacturers, and the article lists specific manufacturers such as Nestle and General Mills and a few others, as bribing researchers, institutions, and organizations to blame fat instead of carbohydrate. And these myths are still coming down to the present, and for all I know, the bribery is still going on. I just mentioned that Consumers Union, in their newsletter, Consumer Health, is still advocating avoidance of saturated fats and consumption of carbohydrate, and also advocating very high blood sugars. My daughter, who is 14, type 1, recently into low-carb diet, but she is having frequent hypos and symptoms. Looks like reactive hypoglycemia. after meals. She was going very low. Any suggestions? Well, reactive hypoglycemia is not due to insulin injections. And if you're a type 1 diabetic and giving insulin to cover your meals, the most likely cause of going too low after a meal is either taking too much insulin or taking it too long ahead of the meal. So what I would suggest is that she reads my book, Diabetes Solution, to learn about the proper use of insulin and a low carbohydrate diet. Just switching to a low carbohydrate diet without knowing how to match your insulin to your meals is not going to do the job.
She might not be using regular.
I have in my notes here R instead of Novolog or Humalog. So you took the words out of my mouth.
Yeah.
She may be using one of the ultra-rapid insulins instead of regular insulin.
Yeah.
What workouts, exercises you would recommend to people with type 1 diabetes? Well, again, you should be reading my book, Diabetes Solution. As a rule of thumb, which doesn't apply to everybody because many people have disabilities, heart conditions, etc., but as a rule, I recommend a combination, the same combination I would recommend to a non-diabetic, namely muscle building exercises like weightlifting, plus true cardiovascular exercises would be things like a recumbent bike or an elliptical trainer, where you could get your heart rate up as high as possible within the confines of your own health situation. So this is not for everybody, but for years I was getting my heart rate above my theoretical maximum heart rate, and I still do. I try to make time to go on an elliptical once or twice a week, and I'm still able to get it above my theoretical maximum. And I think that makes a big difference in terms of long-term cardiovascular disease. However, doing that without normal blood sugars is not going to be the whole answer. You have to have normal blood sugars if you want to avoid cardiovascular disease. My son is 13, diagnosed at 8. Question is my son in danger of high cholesterol and kidney damage affecting him? And if so, how do I prevent this while eating low carb? Well, again, here we have the myth perpetuating to the readers, to the listeners, to my seminars and videos. Everyone is worried about cholesterol, yet the latest Framingham study shows that there's no correlation between cholesterol and heart disease or cholesterol and strokes. If you try to correlate blood tests, the best correlations are with signs of inflammation. So if you have inflammatory factors like C-reactive protein, lipoprotein small a, maybe oxidized LDL, glycated LDL, which you cannot buy commercially. These things are more likely to correlate. So here again is a myth. Now, what you should be worried about are high blood sugars. And just the low carb without doing everything else necessary to normalize blood sugar is not going to do it all by itself. And as far as the kidney damage, Again, the kidney damage is caused by high blood sugars. So let's normalize the blood sugars. And if you read my book, you'll see that I had severe kidney damage back around 1970, and I reversed it. How to best handle the dawn phenomenon as a type 1 that does not use a pump but have great control during the day. Very low carb diet, use of Tresiba and Humalog insulin as needed. So right off the bat, my guess is that this person doesn't have really normal blood sugars because he's using a very rapid acting insulin to cover his food, and it's very hard to match the peak from Humalog insulin with food. Now, I will say I have seen exceptions. In obese type 2 diabetics, I may need diluted Humalog insulin to cover meals because for some reason it takes a long time for the insulin to get absorbed into their bloodstream. So even a rapid-acting insulin like Humalog can be slow, but because it's so potent, I usually dilute it. So what should he do to prevent the dawn phenomenon? One thing is to split the Tresiba into 2 doses, one at bedtime and one on arising in the morning. Now, for some people, the morning dose must be taken maybe 3 hours, maybe even 4 hours before you get up in the morning, which is what I do. So that's really the best I can suggest. He's probably taking Tresiba once daily on arising, and it should be taken twice a day. I have some mild type 2s who can get away with taking Tresiba once a day. Would like your take on Metformin, glucophage XR, a combination of R-alpha-lipoic acid and evening primrose oil or something else is recommended for type 1s. Now, I don't know why this person is interested in these things. I gave the special situations for using metformin or glucophage XR that involve insulin resistance. Otherwise, I don't see any reason for taking it for type 1 diabetes. And as far as the alpha-lipoic acid is concerned, that has been used by others to treat neuropathies. I don't know if it will make any difference in blood sugars. I doubt that it would make a significant difference for type 1 diabetes, and if it makes any difference, it would be for very mild type 2 diabetics. Again, it looks like someone is looking for magic, and he's not likely to find it. I've been insulin-dependent type 1 diabetic for 56 years. Have been on your plan since 1999 when my husband and I visited you. Recently, my cardiologist prescribed 12.5 milligrams metoprolol for heart palpitations. Could this medication skew blood sugars? There is some evidence that this is a beta blocker, that beta blockers can elevate blood sugars. And that's basically it. Next question. I am now having trouble walking due to the deformities in my feet. My first metatarsal drops hard and causes me to pronate, and it makes my knees hurt. The podiatrist said the only option is to surgically rebuild my arch. I would avoid surgery if at all possible. I would first want to try posted orthotics. Orthotics are inserts that go in your shoes to support the arch or whatever part of your foot needs support. And they have to be modified by a competent podiatrist so that the pressure from below is at the right part of the foot, the part of the foot that cures the problem. Now, not all podiatrists do posting, and many of them just prescribe foam inserts, and the foam inserts tend to be compressed by the weight, so it's not that easy to find someone who knows what he's doing. But when I ran the wound care clinic, I was frequently providing orthotics and modifying them myself for the patient, and that's the first thing that I would try well before surgery. By the way, posting means attaching a narrow piece of plastic or leather underneath the orthotic in the right location to correct the problem. And it might be several pieces at different places on the orthotic. Are there any medications to your diet plans for those who recently had their pancreas removed? Yeah, insulin. If you don't have a pancreas, you need insulin. And I suggest you read my book, Diabetes Solution. Diagnosed type 1 at age 34 this summer and have been on a keto diet, less than 20 grams of carb per day, high veggie, moderate protein and fat for 2 months. My blood sugars have been normal, 85 to 100 for 2 months. My doctor said to stop keto because of ketones showing up in my urine. Is there a danger to a keto diet for type 1s? Well, I've seen a lot of patients and read questions by patients who were following what they called the keto diet, and most of them were depriving themselves of protein, and most of them had suffered in their general health by avoiding protein. So if you're not restricting your protein and fat deliberately, your diet may be safe. I just shy away from the whole concept of a keto diet because these people are looking at ketones instead of blood sugars, and your doctor is wrong if he's just objecting to the presence of ketones. He should be looking at how much protein you're eating to see if you're getting enough. Can a low-carb diet lead to hyper or hypothyroidism. Not to my knowledge. My patients, I would say 90% of my patients come in with hypothyroidism. Many of them are on high carbohydrate diets, and when we cut the carbohydrate, the hypothyroidism doesn't change. My boyfriend is a type 1, diagnosed at 23 and is now 57 years old. Carpenter, not overweight. He believes he needs a high-carb diet and has an eating disorder causing him to eat carbs in the middle of the night. He has a continuous glucose monitor, and I can see the levels go from 50 to 400 in swings once or twice a day. He's been to therapy and has tried hypnosis. We'll get him on a low-carb diet you describe in your book, help him with better sugar control and binge eating. Well, maybe, not always. I have some patients who suddenly cut out all the rapid-acting carbohydrate and reduce the slow-acting carbohydrate as directed in the book, and after a week or two, they no longer have any desire for the snacking and binging. But that's not all of them. There are others who still have the problem, and there are tricks in the book geared to cutting carbohydrate craving. Some of them involve the use of GLP-1 agonists that indirectly cause the pancreas to make amylin, which is a satiety hormone that makes you feel less hungry. There are other tricks mentioned in the book. We tried auto-hypnosis, but many patients are not hypnotizable. There are other experimental techniques that we're investigating right now, not yet ready to report on them. So read the book, because we do attempt to deal with overeating in the book. In June 2016, I was diagnosed with type 1 at age 34. I also had my thyroid removed and am on levothyroxine. At my appointment this week, after being on a low-carb diet since September, I'm thrilled to share my A1C is 5.0, and I asked my doctor to check my C-peptide, as I remember you saying that this can improve if you get sugars under control quickly. It went from 0.58 at diagnosis to 1.08. I know that I am still in the honeymoon phase, but wondering how long I will continue to make insulin. I am currently only on 3 units of Levemir at night. Well, I have one patient who's been making insulin for about 30 years, who we caught very early and got her blood sugars normalized within hours of diagnosis. So if we're lucky, that can happen. Now, your sudden improvement in C-peptide, which is a measure of how much insulin you're making, may be informative and may not. As I've explained before, we must measure both blood sugar and C-peptide at the same time. The tradition of just looking at C-peptide gives us very little information. Let's take a non-diabetic who for some reason or other, you manage to get their blood sugar down, let's say to 60. Maybe you had them run a marathon or something. At a blood sugar of 60, a non-diabetic is going to make very little, if any, insulin, because that insulin would lower them further. So how much C-peptide a person makes is dependent upon their blood sugar. And if you don't know the blood sugar, you can't evaluate the value of the C-peptide number, how much sense it makes. So you may be overjoyed, but if you don't know the blood sugar, you're not learning that much from it. My LDL bad cholesterol was 190, but my HDL cholesterol was 72, and triglycerides 118, and total cholesterol 286. Sadly, my endocrinologist suggested a cholesterol medicine. I told her that I would search it and cut out some fat, that I would research it and cut out some fat from my diet. What are your thoughts about my cholesterol numbers? Like I've been saying over and over, you look at lipoprotein small a, C-reactive protein, oxidized LDL, and if you're really worried, you get a CT angiogram and a coronary artery calcium score. Although I don't like to push these visual studies that involve radiation, and CT does involve radiation, if by demonstrating you have no cardiovascular disease, you can avoid using a statin, it's worth getting the tests done. But certainly total cholesterol, we now know, has no meaning when it comes to cardiac risk. And even the LDL has no meaning unless you know the particle size. And the small, dense LDL particles are the potentially harmful ones. The large, buoyant ones are not harmful. So and I check all these on my new patients. So if you don't know your LDL particle size, there's no sense in looking at the total LDL. I'm a type 2 diabetic on Metformin SR, that's slow release, 2,000 milligrams a day with an A1C of 5.7. I remind everyone that in my experience, the generic Metformin does not work as well as the brand glucophage. I found it darn near impossible to exercise in the evening, skipping it more than I perform it. First thing in the morning, I usually can do it. However, typically my blood sugar is 89 prior to exercise, 112 after exercise. What strategies might you suggest to help me handle this? Well, there's a number of things. You can try the rapid-acting glucophage a couple of hours before you exercise. You can give an injection of diluted rapid-acting insulin, possibly a half hour, 40 minutes before exercising. That's about all I could think of right now. Sometimes giving a beta blocker, rapid-acting beta blocker, small dose before exercise prevents the blood sugar increase, but that would be a last resort. I'm a type 1 since I was 12 years old. I am now 47, So this person is a survivor. I have no health insurance and no diabetes doctor. I have many people around me that recommend and use Dr. B. I have a very disabled child of 21 years that I need to outlive. What should I do? My A1C is currently 8.1. Well, that's a pretty darn high blood sugar. And at that blood sugar, this person is not likely to outlive his child. So the only thing I can think of is getting my book Diabetes Solution and following it. I follow the 6-12-12 eating plan. That's 6 grams of carbohydrate, 12 for breakfast, 12 for lunch, which is what I recommend for the average adult and less for children. I find I cannot ride my bike to work without experiencing low blood sugars, without experiencing lows if my sugars are under 100. What am I doing wrong? Well, first of all, this person may be taking insulin. I'm guessing that that's what the person is doing, and he may be taking insulin for breakfast, and he may have to lower the dose of insulin. Another thing that he or she should do is carry liquid glucose along in case the blood sugar does drop, and you might want to carry a little plastic shot glass so they can measure the amount that you're doling out for a particular low blood sugar. Again, the book Diabetes Solution will give you some tips, but you have to find out the cause of the low, and it might be a combination of the exercise and your basal insulin. You might want to take a lower dose of basal insulin in the morning, and then take the balance of the dose after you get to work. I don't know. It's trial and error. Next question. This question is incomplete. I live 50 miles outside of Chicago, Illinois. Would like to know if there are any doctors close to me that practice Dr. B's methods. Again, I know of virtually no MDs in the USA, or else, well, I know one MD in Bahrain who practices my methods, but and I know a PhD in Mexico who treats patients and practices my methods. But in the USA, the doctors who practice my methods that I know of are type 1 diabetics themselves, and they use my methods for themselves, but because it takes so much time to spend with the patient to teach them my methods, they can't afford to spend the time with their patients, so they don't use my methods on their patients. Doctors are not paid for spending time with people. They're paid for doing procedures. I'm a type 1, have a hard time keeping my blood sugars under control. If I take a half unit of regular insulin with my 12-gram carb meal and wait 30 to 40 minutes to start eating, my blood sugar will rise by 1 to 2 millimoles per liter, which would be about 18 to 36 milligrams per deciliter. It does come back down after 3 hours by itself. If I take 1 unit of regular, my blood sugar will stay stable for 2 hours, but will go too low subsequently. Please advise. Well, it sounds to me like you need between a half and 1 unit. So that would be 3/4 of a unit. You either would have to estimate it with a syringe that reads half units, but you can estimate 1/4 of a unit, or you can dilute the insulin, and if you diluted it, for example, 3-to-1, a half unit would actually be 2 units measured on the syringe, and a 1/4 unit would be 1 unit measured on the syringe, making it much easier.
That's it.
Okay, that's it for our teleseminar right now. Our next teleseminar will be Wednesday, July 25th, 2018. Please join me then. Thanks a lot for listening right now.